Dr. Karnav Panchal.
Thank you. Thank you, AFPA, for inviting me for my lecture on causes of shoulder pain and its management. So let's start from the basic first, the shoulder anatomy. The shoulder is a ball and socket variety of the synovial joint where the ball is formed by the humeral head and the socket is formed by the glenoid. If we talk about the superficial soft tissue coverage around the shoulder joint, on the anterior aspect, we have two muscles, that is pectoralis major and minor muscles. On the anterior, lateral and posterior aspect of the shoulder joint, we have this deltoid muscle. And on the back, on the upper aspect, we have trapezius, and on the lower part, we have latissimus dorsi muscle. If we talk about the deep soft tissue coverage around the shoulder joint, then we have this group of muscles, which is known as the rotator cuff muscles. On the anterior aspect, we have this subscapularis muscle, which is inserted on the lesser tuberosity of the humerus and which is the prime internal rotator of the shoulder joint. On the posterior aspect, on the upper part, we have supraspinatus muscle, which is inserted on the upper part of the greater tuberosity of the humerus, which is the abductor of the shoulder joint. And in the lower part, we have infraspinatus and teres minor muscles, which are inserted on the posterolateral and posterior aspect of the greater tuberosity and which are the prime external rotator of the shoulder joint. If we consider the ligaments around the shoulder joint, then this coracoclavicular ligaments and the glenohumeral ligaments, which has got superior, middle, and inferior glenohumeral parts, are very much important. The shoulder is the least stable but the most mobile joint of our body. And if we consider the stability of the joint can be compared with the golf ball and a golf tee. You can see that the contact surface between the golf ball and golf tee is very less. Likewise, in the shoulder joint also, at any given point of time, the contact area between the humeral head and the glenoid is only 30%. So shoulder is a very unstable joint. If we consider the stability of the shoulder joint, then we have the static stabilizers in the form of superior, middle, and inferior glenohumeral ligaments and the glenoid labrum, which effectively deepens the glenoid socket. The dynamic stability of the shoulder joint is provided by the deltoid muscle, which prevents the inferior subluxation of the humeral head, and the rotator cuff muscles, which keep the humeral head centered over the glenoid during various shoulder range of motion. The causes of shoulder pain can be divided into two major groups, that is arthritic or bony related causes and non-arthritic or soft tissue related causes. In arthritic causes, we have osteoarthritis, inflammatory arthritis or rheumatoid arthritis, post-traumatic arthritis, rotator cuff tear arthropathy, osteonecrosis or avascular necrosis of the humerus, and infective arthritis. In non-arthritic or soft tissue related causes, we have subacromial impingement, rotator cuff tears, subacromial bursitis, adhesive capsulitis or frozen shoulder, shoulder instability, biceps tendinitis, and referred pain. So, in adults, in generally adult population, shoulder pain is because of sports injuries or instability, whereas in middle-aged population, the pain is because of arthritis or adhesive capsulitis or rotator cuff tears. If we consider site and character of pain, the pain due to subacromial impingement, rotator cuff tears, AC joint pathologies, or calcific tendinitis is generally sharp and shooting in nature and is concentrated around the shoulder joint. Sometimes it is radiating over the upper part of the arm and forearm. Whereas the pain due to glenohumeral arthritis and instability is dull aching in nature and it is concentrated around the shoulder joint. Acute pain is found in fractures and dislocations, and chronic pain is generally found in arthritis. Pain with overhead activities are generally found in rotator cuff tears. Pain with cross-body adduction is generally found in AC joint related pathologies. Pain on reaching the back is generally found in adhesive capsulitis or frozen shoulder. Pain worsening at night is commonly seen in rotator cuff tears, adhesive capsulitis, infection or tumors, and sudden onset of intense unrelenting shoulder pain followed by flaccid paralysis is commonly observed in brachial neuritis. We have sometimes referred pain over to shoulder joints because of cervical nerve root irritation, and certain other organs pathologic pain may be referred to the shoulder joint, like pain of MI, diaphragmatic irritation, and liver and gallbladder diseases. If the patient has associated neurovascular symptoms like arterial ischemia, Raynaud's phenomenon, venous congestion, cold intolerance, or ulnar paresthesia, we can think of thoracic outlet syndrome. If there is associated numbness, tingling, and weakness, we can think of cervical radiculopathy. And if the patient is having constitutional symptoms in the form of fever, anorexia, etc., then the patient may be suffering from infection and tumors around the shoulder joint. So we need to physically examine the patient properly. We have to look the front, side, and back of the shoulder joint, and we have to feel the bony and soft tissue structures around the shoulder joint. We have to note down the range of motion of the shoulder joint. We have various range of motion at shoulder joints like abduction, this is adduction, this is forward flexion, this is external rotation, this is internal rotation in the front, and this is internal rotation at back. So if the patient is having pain during abduction, particularly 60 to 120 degree of abduction, then we may think of subacromial impingement. And in these cases, the pain is because of abnormal acromion morphology, where in some cases we find this hooked acromion, and because of it the subacromial space is less, and during abduction the tendon of the rotator cuff gets impinged over the subacromial spur and the patient feels pain. In supraspinatus stare, we have drop arm sign, which is positive, in which the patient is unable to actively abduct the shoulder joint. In infraspinatus stare, we have external rotation resistance test, which is positive, in which the patient is unable to externally rotate the arm against resistance. In teres minor test, we have Horn-Blower sign, which is positive, in which the patient is unable to actively externally rotate the arm when the shoulder is kept in 90-degree abduction. In subscapularis, the lift-off sign is positive. In labral injuries, O'Brien test is positive, and in biceps tendon rupture, we have Speed's test, which is positive, in which the patient experiences pain in the front of the arm when the elbow is flexed against resistance. And in long head biceps tendon tear, when the patient flexes the elbow, we typically find this bulge just proximal to the elbow joint, and this is known as Popeye sign. When there is anterior shoulder instability or recurrent shoulder dislocation, when we keep the patient's arm in abduction and external rotation, that is the throwing position, the patient feels pain, and which is known as apprehension test. So this physical examination has to be completed with investigations, and shoulder x-rays are the basic investigation tool, where certain glenohumeral joint pathologies, calcific tendinitis, rotator cuff tear, arthropathy, and fractures and dislocations can be diagnosed. So this is the normal shoulder joint x-ray, AP view. We can see that the contour of the humeral head and the glenoid is well maintained. The distance between the acromion and humeral head is around 1.1 to 1.2 centimeter, which is well maintained. In case of osteoarthritis of the shoulder, the joint gap is reduced, and we have typically inferior humeral osteophyte, which is the hallmark of osteoarthritis of shoulder. But in case of chronic neglected rotator cuff tears, we have this condition known as rotator cuff tear arthropathy, in which there is superior migration of the humeral head. The distance between the lower border of acromion and upper border of humeral head is reduced, and there is erosion of the humeral head and glenoid bone. CT scans is helpful when we suspect any bony pathology like fractures and dislocation. This is a normal axial cut of the shoulder joint. Here is the humeral head, here is the glenoid, and in dislocation we can find that the humeral head is dislocated anterior to the glenoid. In glenohumeral arthritis, the CT scan is helpful about knowing the wear and tear of the humeral head and glenoid, and we can find numerous osteophytes surrounding the joint. MRI is definitely helpful for diagnosing soft tissue condition. So this is the normal shoulder joint coronal cut, where we can see that there is almost 4 millimeter of axillary pouch on the lower side of the humeral head. In frozen shoulder, this pouch is obliterated. This is the rotator cuff tear. This is the normal MRI coronal scan. We can see that here the supraspinatus tendon is very much inserted on the greater tuberosity of humerus, whereas in supraspinatus tear, when the tendon gets chipped off from the humeral head, the tendon is retracted medially. This is MRI in case of labral tears, which is commonly found in recurrent shoulder dislocation. Here is the axial scan. You can see that here anterior and posterior glenoid are intact, attached to the glenoid, but in case of labral tear, we can find such kind of MRI where the labrum is detached from the glenoid. This is another example where anterior and anterior-inferior part of the labrum is detached, and this condition is typically known as Bankart sign, which is very much visible on MRIs in recurrent shoulder dislocations. So conservative treatment can be an option for certain conditions like frozen shoulder or partial rotator cuff tears in the form of physiotherapy, pain control medicines, corticosteroid injection, and in certain cases of frozen shoulder, we can also mobilize the shoulder under anesthesia. So in surgical treatment options, we have shoulder arthroscopy, which is a specialized procedure. Here we have 4 mm tiny arthroscope, which is attached to a camera and a light source, and this camera is attached to a monitor, so that whenever we insert this arthroscope inside the joint, the camera displays the internal structures of the joint on the monitor, and we can treat the condition. So this is a specialized shoulder distractor, which we use during the scopy. The patient is going to be operated for the right shoulder arthroscopy. The patient is lateral decubitus position, and this is a specialized joint distractor which we have devised to maintain the position during surgery. So in refractory cases of frozen shoulder, we treat them arthroscopically. We release the anterior capsular structures, various ligaments inside the joint, posterior capsular structure, and at the end of the procedure, we have the full range of motion on table only. So this is the arthroscopy done for labral tear repair, commonly found in recurrent shoulder dislocation. So here is the humeral head, here is the glenoid, here is the labrum which is detached from the glenoid. So this labrum is getting mobilized for the repair over here. So we used special implants to repair the labrum. These are known as suture anchors. These are the screws which are inserted into the glenoid bone, and the threads are attached to the anchor, and these threads are passed sequentially from the glenoid labrum, and it is attached over the glenoid. The knots are sequentially tied. So to summarize, here is the humeral head, here is the glenoid, here is the detached labrum, here is the humeral head heel sac defect. The anchor is inserted into the glenoid and the threads are passed through the labrum, and a nice soft tissue bumper is created in front of the humeral head so that there are less chances of humeral head getting dislocated again. This is the arthroscopy which is done for rotator cuff repair. So this is the long head of biceps tendon which is stenotomized because biceps tendon is a pain generator and it can cause pain post-operative also. So we just stenotomize the biceps tendon from the upper pole of the glenoid. So this is the detached subscapularis tendon from the lesser tuberosity of the humerus. To repair it, we have to insert one anchor in the humeral head. The threads are attached to the anchor and the threads are sequentially passed to the subscapularis tendon, and the tendon is repaired back to its position. Now the arthroscope is moved into the subacromial space. Here, this is the special instrument shaver which is used to clean the subacromial bursa. You can see that underneath there is rotator cuff. Here is the rotator cuff which is torn from its insertion site on the greater tuberosity. So we insert anchors over this position. This is the first anchor which is introduced, and this is the second anchor which is introduced. And these threads are sequentially passed from the rotator cuff, and the rotator cuff is repaired back to its position. So to summarize, here is the subscapularis tendon which is torn from its attachment on the lesser tuberosity, and with anchor it is repaired back to its normal position and normal tension. And this is the humeral head, this is the glenoid, and this is where normally subscapularis and supraspinatus and infraspinatus tendons are attached. They are detached and retracted over here, and these tendons are repaired back to their position with anchors. Here, they are repaired back to its position. So this is the result. The patient has been operated on right shoulder, and at the end of 3 months, the patient is having full range of motion without any pain. Hemi replacement arthroplasty is an option for surgery when the humeral head is defected. Here is a young male patient, an alcoholic one. The patient's right shoulder, there is a restricted range of motion with pain. You can see that the abduction, forward flexion, internal rotation, external rotation, all are limited. Here is the X-ray. You can see that here, the humeral head, there is chondrolysis. This is the MRI showing avascular necrosis of the humeral head, and this is the CT scan showing subacromial or subchondral cyst. This is the intraoperative finding where there is chondrolysis. Yeah, there is chondrolysis, and here is the glenoid, which is normal, which is not replaced. So these are the implants, and this is the final X-ray, and this is the follow of the patient compared to the preoperative picture. The patient is having full range of motion without any pain. So this is a special condition in which there is comminuted fracture involving the humeral head. We have replaced it with the artificial head, and this is the patient function at the end of 3 months. Total shoulder replacement is done when the glenoid is also affected. Here is a young female patient. The patient's left shoulder is restricted range of motion and with pain. If you see the X-ray, there is monoarticular rheumatoid arthritis involving the shoulder joint, the glenoid, and the humeral head. Both are destroyed. The intraoperative findings where the head is deformed, the glenoid is eroded and it is replaced with the glenoid implant. And this is the patient's range of motion at the end of 3 months compared to preoperative side. And this is the reverse shoulder replacement, which is recently introduced in India almost 5 to 6 years back. In this condition, normally shoulder joint, the ball of shoulder joint is formed by the humeral head and the socket by the glenoid. But in reverse shoulder, the ball is formed by the glenoid and the socket is formed by the humeral head. And this is done in special situations like rotator cuff tear arthropathy. When in chronic neglected shoulder rotator cuff tears, the patient has got a rotator cuff tear arthropathy. This is the case, 80-year female patient. You can see that the shoulder is very much arthritic and it is replaced with this kind of special implants. And it is done in smaller incision also. So the take-home message is diagnosis is the key to treat chronic shoulder pain successfully. Many patients with chronic shoulder pain in old age with rotator cuff tears have been misdiagnosed with frozen shoulder. If the X-rays are normal, the MRI and CT scan are must to rule out any soft tissue or bony pathology. Recent implants for total shoulder and reverse shoulder replacement have provided excellent surgical outcomes if utilized in appropriately indicated patients, and refer to a shoulder specialist orthopedic surgeon whenever necessary. Thank you.
Thank you very much for informative lecture. Now I request Arvind Panchal, Dr. Arvind Panchal, to give memento to Dr. Karnav Panchal. Karnav Panchal is his son, father to son.
Father is giving memento to his son, and Dr. Karnav Panchal